Today on the Diabetes Podcast.
It's quite common for us to think of diabetes as a condition where the body doesn't produce enough insulin. And while technically that's true, there's not enough insulin to overcome the resistance that's going on. It doesn't mean that the beta cells aren't working really hard to try to do that, or they're not still producing insulin, because they are. At diagnosis, on average, people have already lost 50% of their functioning pancreatic beta cells. After diagnosis without intervention, the continued rate of pancreatic beta cell loss is usually 4 to 6% per year.
Hello and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, today is the last of our core dysfunctions wrap-up series. We talked about a lot of stuff, so much stuff that I'm just going to tell you to go ahead and listen to those other 2 episodes. But today we're really going to try and bring it home, try and kind of tie it all together and give you some really good action steps that you can do to start taking prediabetes and type 2 diabetes and working towards putting those into remission.
Exactly. And a major focus on this episode is going to be beta cell disruption, if you will, beta cell depletion, and looking at the question, like, do I have beta cells left? Are they still working? What does this even mean? How many do I need to have? Was that even something to ask? Is there a specific volume that means they'll work? And if I have to take insulin, is this forever? Is this something I will need to be on for the rest of my life? So we're going to dive into that and hopefully answer a lot of those questions today. So I'll go ahead and just give the answer, which is that the pancreas is not broken. A lot of the core dysfunctions that we've talked about up until this point play a role in the pancreatic beta cell function. And so we'll dive into that quite a bit.
And just for the person that is just absolutely new to this, just tuning in, when we say beta cells, those are the cells in your pancreas that make insulin.
Yes.
Correct? Okay.
Yes. I was going to talk about that, but I'm glad you asked. Don't let me get to it.
I don't know a lot, but I know that much at this point in time. After a year of doing this, I can tell you quite confidently that the beta cells make insulin. That's about it.
All right. That's not true. You know more than that. But yeah, the pancreas is not broken. It's just that this system is quite exhausted. And so basically the beta cells are produced by the pancreas. They're in your pancreas, the cells that make insulin. So we're going to talk about why they quit, beta cell exhaustion, and what it means, and the research on whether you can rest them, recover them, and even regrow them. So the pancreas sits behind your stomach, kind of on top and behind, kind of nestled up against your spine there. And it's about 6 inches long, and it's really protected, draped over the top of your large intestine. So very deep in the body. You can't really poke at your pancreas. It's really protected, which is why I think a lot of the problems with the pancreas are a little more difficult to detect. And other than a direct inflammation of the pancreas called pancreatitis, you really can't feel things that are going on with the pancreas. But anyone that's had pancreatitis will tell you can feel pancreatitis. It's supposed to be a very painful condition, but not related to what we're talking about when we talk about inflammation in this regard. So the pancreas has several roles. Digestion is a huge role of the pancreas, and the other is hormone release, namely insulin and glucagon.
Now, when you say digestion, it's helping with digestion, right? It's not, I'm thinking in line with the digestive tract. It's a supplementary organ. It facilitates in digestion, but there's not food going through it.
No, there's no food going through it. It makes enzymes that help break down fat, protein, carbohydrates. I think fat is the one that I always think of in terms of like enzymes that the pancreas releases, but it also helps with the protein and fat breakdown in your small intestine. And that's about 95% of what your pancreas does by volume, but definitely not by importance. Let's say it's all important, of course. So the other 5% by volume is hormones, and specifically your blood sugar hormones. That would be the beta cells, the insulin producing cells of the pancreas, and glucagon. So glucagon is like the anti-insulin hormone. And we talked about those a lot in the last episode.
And correct me if I'm wrong, glucagon is produced by your alpha cells, correct?
Right. Okay. Exactly. Glucagon is produced by the alpha cells of the pancreas. And they all kind of hang out on these islets of Langerhans area of the pancreas. And they're little clusters of cells scattered throughout your pancreas, about 1 million of them in total. And beta cell is the one we're going to focus on the most here today, but we'll talk about the glucagon just a little bit. But the beta cells are the only cells in your entire body that can make insulin, which is why we're going to focus on the beta cells. If your beta cells are tired, there's no other mechanism that can pick up the slack. So like nothing else is going to produce insulin other than the beta cells. No backup system. No second string pitcher. This is it. So we're really talking about exhaustion of the pancreatic beta cells over time. When you hear something like type 2 diabetes being a progressive disease, this is a big part of that, is this eventual burnout of the pancreatic beta cells. So on a normal day, you eat breakfast. When the oatmeal hits your gut, the carbs get broken down into glucose. Glucose enters your bloodstream, and the insulin is the key that unlocks the door to the cell to let the glucose from the food that you've eaten get inside where energy can be made. And the beta cells have a sensor on their surface that constantly monitors glucose. So as the glucose rises, those sensors flip on and the beta cells immediately release insulin into the blood. And insulin tells the body what to do with the sugar, unlocks that door to the muscle cells, fat cells, liver, so that you can get it out of the bloodstream, because sugar at high concentrations in the bloodstream wreaks havoc on your body. I used to often give the analogy that if you invited a lot of people to your house for a party, but then locked the doors so they couldn't get inside, and you didn't show up with food or anything else, you're going to have a bunch of trash on your lawn when everybody leaves. Maybe like they can't get inside to not disrupt the neighborhood, so they have a party outside and throw their trash on the ground because all the trash cans are inside. So it's just wreaking havoc out there. So we need the glucose into the cell where energy can be made and where it doesn't create havoc.
Got a little bit different analogy. Let me know if this works.
Okay, sure. My analogies are a little broken.
No, you're good. So when we talk about sugar, we're talking about glucose, we're talking about energy, right? My body runs on energy. The car runs on fuel, gasoline, right? Well, the gas station is where we normally get our gas, but the gas station gets it from fuel trucks, right? So the fuel trucks deliver the energy and they move up the highways and all this other kind of stuff. But insulin is maybe letting the fuel truck into the parking lot for the gas station to even distribute the fuel there. And if insulin's not there letting the fuel trucks in, the fuel trucks are just getting backed up on the road going up to the gas station, maybe backed up onto the highway. And all this energy is on the highway creating traffic jams and all this other kind of stuff because it needs to get out of the fuel trucks and into the gas station so that it can be used up by your body, or in this analogy, the cars. Does that work?
Sure.
Okay.
It works for me. If your beta cells are working right, the blood sugar levels come up. The beta cells sense that the blood sugar levels are rising. They come with the key that unlocks the door to the cell. And over the course of the next 2 hours, gets that sugar into the cells so that the blood sugar comes back down within 2 hours.
Okay.
The beta cells stop, calm, quiet. Everything's over until the next meal. So it's a real-time feedback loop. Like the glucose level is still rising, release insulin, glucose level is still rising. So it is a perfect match between glucose and insulin to get the glucose into the cell.
So just want to make sure I understand correctly. So in normal physiology, I would expect higher blood sugars for about a 2-hour window after eating, as the body's trying to get it out of the bloodstream and into the cells. Is that correct?
Yeah, to a degree,
okay,
yes. Okay. Yes. Insulin is designed to react really quickly to changes in glucose. So there's a first phase insulin response that releases insulin immediately when glucose enters the body and the bloodstream, and carbohydrate digestion begins in the mouth. So it's a very quick system. In the normal state, in normal physiology, if the beta cells are working right, the blood sugar levels rise from the food that you eat, and beta cells release insulin. Blood sugar comes back down within those 2 hours. But that's not to say that the insulin isn't released within seconds. It's pretty instantaneous. It just, you don't have this huge dump, because it wants to make sure it matches the food as the food breaks down and gets in your digestive system and into the bloodstream, so that you have insulin there to match it. So the beta cells are paying attention to your blood sugar every single moment of every day, 24/7. They don't get a break in paying attention. They're always going to see what the blood sugar level is and make sure that the insulin matches that. And it has the receptors on the outside of the cell to understand what the glucose level is and see if it needs to match it to keep that homeostasis of the blood sugar, which should be about 70 to 110 before meals. And any other time, it's usually 140 or less, even at the 2 hour mark. Sometimes you do have this really big spike, quite higher than that, depending on how simple the carbohydrates from the food that you eat or what your first phase insulin response looks like. You could go really high and come down really quickly as the insulin is released in response. The big thing is basically at that 2 hour post-meal mark, what do the blood sugars look like? Are they back down under the 140 point? Is really what to pay most attention to. So the beta cells are also releasing a small amount of baseline insulin all the time. And in diabetes circles, this is called basal insulin. Basal, baseline is in the background. It's completely irrespective of food that you've eaten, because your body is always utilizing glucose in some fashion to repair cells, to fuel your brain, even though you don't really need insulin for that, as we talked about in a prior episode. But you always need energy, so the insulin cells are there to match the glucose to get it into the cells.
But when you say that the pancreas is releasing like a basal equivalent, it's not that your pancreas is releasing two types of insulin like you would have in a rapid acting and a basal. It's just... So
if you were to take an exogenous, meaning it's coming from the outside, because you in general need to inject hormones. If you were taking an exogenous insulin, the reason you take two different types, you have a basal insulin injection because there's an enzyme attached to that sits in the fat cell with the insulin, so that all that insulin doesn't get released all at one time. So that enzyme has a predictable breakdown over about 24 hours. So it's going to release that insulin injection in a steady amount over the course of 24 hours. That's why you can't use a basal insulin in an insulin pump, and you wouldn't take your basal amount before meals because it wouldn't work fast enough. The basal is simply meant to be the baseline needs for insulin, because when you're injecting exogenous insulin, the goal is always to match your endogenous, meaning you produced it yourself. You want to match what your body would do normally if it could. That's the goal, always. So really, I think sometimes we don't pay attention to what our bodies do naturally because it was just working. And personally, I don't want to. I don't want to think about I have to breathe. I want my body just to breathe. I want it just to work. And I think anybody with type 1 diabetes can tell you that's also their goal. They want their pancreas just to work. Like it'd be great if it just did what it was supposed to do. And in type 2 diabetes, the pancreas does what it's supposed to do until it begins this gradual pancreatic beta cell burnout. And that also happens in type 1 diabetes, but that burnout usually is way more rapid because the immune system is attacking the pancreatic beta cells of the pancreas. And so that happens over the course of about 6 months to a year. Whereas in type 2 diabetes, you have this more gradual reduction of beta cell function over the course of several years. So what goes wrong in type 2 is stage 1, you have insulin resistance that comes, and the muscle cells, fat cells, and liver cells stop listening to the hormone signaling of insulin. They don't listen well, and that key gets kind of gunked up as if you stuck the key in Crisco before you tried to unlock the door to the cell. And the cells need more insulin to do the same job that they used to could do on half as much or less. So the body asks the pancreas to do more, and the pancreas, being an ever faithful servant, says okay and produces more insulin to try and overcome the resistance that's occurring. And then it ramps up production, and the beta cells are just cranking out 2 times, 3 times, 5 times the amount of insulin. So I will often tell someone who has type 2 diabetes, they think they don't have any insulin. And I'm saying, no, actually, you're probably making 3 to 5 times more insulin than I'm making. You just have such a strong resistance. In early type 2 diabetes and even in pre-diabetes, your insulin levels can be quite high, way higher than somebody without diabetes because the beta cells are working overtime. And I think it's quite common for us to think of diabetes as a condition where the body doesn't produce enough insulin. And while technically that's true, there's not enough insulin to overcome the resistance that's going on, it doesn't mean that the beta cells aren't working really hard to try to do that, or they're not still producing insulin, because they are.
So I got an analogy for this one. You ready?
Okay, let's hear it.
All right. So we got some people in our life that are dealing with diminished hearing in later life, and they like to watch certain shows. But as a result, they have to watch certain shows at levels that would be unacceptable to almost anybody else. So it's not that the television is not making noise. It's that the inability to hear has resulted in the television having to be turned up to 11. And on a long enough timeline, it's probably going to blow out the speakers on the TV. Is that?
Yes. Okay. And that brings me to the second stage. So you have this increased production to try to overcome the resistance. And then you get into beta cell stress. You can imagine if you were just pulling double, triple, quadruple shifts at work, you would feel quite burnt out. And the same thing happens to the pancreas. After months or years of double shifts, these beta cells start showing signs of strain.
So, and again, is it safe to say that in, let's just call it early to mid-phase diabetes, your pancreas has probably produced a lifetime supply of insulin in your 50s? You know what I'm saying? Like the organ is designed to produce X amount milliliters of insulin over the course of whatever normal human life is. But due to increased insulin resistance is being called to up production, but it may only have so much total production over the life of that organ. And as a result, it's burning out before you are, if for lack of a better description.
there's some fault in that. It is true that you could be producing a lifetime's worth of insulin. That could absolutely happen. But the idea that the fact that you've now reached your lifetime max and the beta cell has died, that's not true. So once you have this strain on the beta cells of the pancreas, they do start to show signs of strain, and they are making insulin a little more sluggishly, if you will, less efficient. And the first phase insulin release is one of the first things to kind of show signs of this. And that's that burst of insulin release that's supposed to happen the moment you start eating. But now after you eat, the blood sugar gets higher than it should right off the bat because the insulin is late. And that's what would show up on a glucose tolerance test, for example. Or you could, if you wore a continuous glucose monitor, this could show up as really outrageous spikes.
So it's starting to kind of manifest in the physiology, similar to if you were taking your basal insulin at mealtime as opposed to 15 minutes before mealtime. Is that correct?
I don't love that analogy.
What you're saying is it, and we talked about this before, is the taking the basal insulin before eating gives it time to operate, whereas normally it would.
Basal insulin is just so not designed to cover mealtime in that way that it just doesn't.
I'm sorry, bolus. Is that better?
That is better.
Yeah, I misspoke. Sorry. Starting to behave as if you had, rather than taking my bolus 15 minutes prior to eating to allow it to kind of kick into high gear, the pancreas is behaving that same way. It's late to react. And as a result, that blood sugar got too much of a head start, that it went up real high, and then it's going to take longer for it to come back down. Or at least you're going to spend more time than you want to at a blood sugar level that's not healthy for you at any time. But again, it is going to be, I'm going to spend more time in there because that insulin is late to activate. Is that more accurate?
Yeah, and I'm just going to clarify that. What I believe I heard you say was that if you were taking an exogenous, you were taking a shot of rapid acting insulin, you've heard me talk to people quite a lot about making sure the timing of that rapid acting insulin is usually 15 to 20 minutes before they start eating, which is a really challenging part of having to take a rapid acting shot as part of your diabetes plan if you weren't producing insulin on your own or not producing enough. And so what I heard you say also was that it's kind of like if they didn't do it 15 minutes before, but did it when they started to eat or even 10 to 15 minutes after they ate, you would see this huge spike in blood sugar and it would take longer to come down. And that is very much what you see when the body doesn't produce insulin quickly enough. Same, because anytime you're giving an exogenous shot, the whole goal is to mimic normal physiology. Yep, very good. So then you have stage 3, which is pretty complete beta cell exhaustion. So these cells are genuinely crispy burnt at this time. They are pretty exhausted. They've been overworked for years, and some of them are starting to dedifferentiate. Some are entering a kind of dormant state. So the body still needs high amounts of insulin because of the insulin resistance, but the pancreas can no longer keep up. And the blood sugar starts climbing into ranges that are consistent with a diagnosis of diabetes. And then stage 4 is beta cell loss, where the exhaustion has gone on long enough that some of the beta cells actually could die. And that word is apoptosis, or programmed cell death. Or they could dedifferentiate to such an extent that they stop functioning as beta cells altogether. And that's the stage where people end up on insulin therapy because there's literally not enough insulin function to manage the blood sugar levels. So you got insulin resistance, which is the beta cells overcompensating. Then you've got the beta cells starting to slow down. Beta cells are exhausted, and then beta cell could be dying or completely shut down, like dormant, if you will. And so I said a word. I saw your eyebrows raise. So I'm going to go ahead and talk about dedifferentiation, which is, it used to be believed that the pancreatic beta cell died. Like they just went kaput. You're out of luck. You got to take insulin forever. You'll never get off of it. That was the story that many people were told 20 or so years ago or longer. And so this was a huge discovery in diabetes research. Dedifferentiation was about 15 years ago. Well, over the past 15 years. And everybody had assumed until the study, this was done by Dr. Achille, I think I'm saying that right.
Okay.
So researchers looked at beta cells from people with type 2 diabetes and realized that a large portion of these beta cells weren't dead. They were just transformed. They were regressed back to a more primitive cell state. Like they'd taken off their work uniform and put pajamas on and lounging on the couch. They were like, forget this. You have worked me too hard. I'm just going to sit here and chill and do nothing. They were still alive. They just weren't what you could say well. They were alive, but not well. And they had just stopped acting like beta cells. And that's very important because if the beta cell is dead, it's dead. You can't revive it or bring it back. But if it is just dedifferentiated, you can take those pajamas off maybe and put the work uniform. You could be like, let's go rally and get them, coaxing them back to work. So when somebody is on a medication that could help give their pancreas a bit of a break, or if they are able to reduce the glucotoxicity, the high blood sugars over time, the lipotoxicity, the free fatty acids that are creating a lot of the inflammation, perhaps somebody would lose a significant amount of weight to do that. What's actually happening is they're giving their beta cells a vacation. And during that vacation, sometimes the dormant beta cells put on their work uniform, punch the clock, and get back to work. And the remaining beta cells are less stressed because there's more workers on hand to get the job done.
To me, this almost sounds like a one-to-one with like physical therapy. Like if you've blown out a knee or whatever that is, clearly I can't go right back to lifting. I can go back to making the knee move under very light loads and an
like
increasing range of motion. And then there hopefully is a progression. But the very first thing is take the weight off. I'm not going to heal like in the bottom of whatever terrible squat it was that I did that blew the thing out in the first place. I have to drop the weight first. I have to get out from under the stress of what caused the injury in the first place and allow that joint, or in this case, allow those beta cells the opportunity to recover.
I like that. And so when the beta cells start clocking back into work, you can see a pretty dramatic decrease in blood sugar levels, which is a good thing. And the beta cells can come back online. And one trial that really showed this was the direct trial, where we talked about last episode, where about half the people were able to achieve diabetes remission. And you can't do that if you don't have functioning beta cells. And so if they were able to lose enough weight to give their pancreatic beta cells a break, then, and even more specifically, that visceral fat around the internal organs, then they were the most successful people at diabetes remission, those who could do that and keeping remission over time. So that I think brings us to a discussion of a little bit more of what has these beta cells burning out in the first place. And we've talked about this a lot on different podcasts, but to kind of bring it together a little bit more, because we don't want to just have them burn out again. We want to look at what the cause is. There's some main drivers of this. So number one would be high blood sugar. That's like which came first, the chicken or the egg sometimes. And it's a lot of that with that avalanche effect that we talked about with insulin resistance and type 2. So the high blood sugars are called glucotoxicity. And that's when the blood sugars are consistently elevated for months or sometimes even years. And that high glucose itself becomes toxic to the cells. And they start to malfunction, which is this feedback loop of high blood sugar damages the cells. And those are the cells that are supposed to lower the high blood sugar. And then you have chronic high free fatty acids, which is lipotoxicity. And when visceral fat leaks free fatty acids into the bloodstream, that free fatty acid creates the lipotoxicity that can directly damage the beta cells. So then there's chronic inflammation. And so you have inflammatory signals from your gut, from visceral fat specifically. They can all flood your pancreas with stress signals, with these inflammatory cytokines. And these beta cells live in this sort of inflammatory soup, if you will. And over time, they get damaged just by the environment. There's a saying that you are the 5 people you hang around with the most. And they're just in this very volatile, hostile work environment that they're being overworked and underpaid and underfed, and they're just unhappy. And then we have oxidative stress and free radical damage related to oxidative stress. And the beta cells are very vulnerable to this because they don't have a lot of protection from free radicals. They have a lot less protection from free radicals that other cells have. So they are under-armored in this very high sugar environment, high inflammation, high stress, modern life where free radicals are everywhere. And then just plain old overwork, years of cranking out 3 to 5 times the normal insulin production.
Running that engine at 8,000 RPMs all the time.
That is the exact analogy that I would use. You've got that engine revved to the max constantly. So thankfully, after running that engine in the red zone for years, the engine doesn't completely blow up. You might need to repair some gaskets, and I don't know cars, but I'm like,
I was like,
yeah, where is she going?
Come on, give it to me. Tell me what happens.
Nope, not going to tell you. Not going to say nothing. You got to change the oil. I know that. That's about it. So then we talk about the things that can damage them. We want to look at, can this regrow? Can you regrow beta cells? Because that was a little bit of the promise in the beginning to have this. So can they actually grow back? And if you'd asked 20 years ago, it would be absolutely not. They're dead. Beta cells died. Good luck. Here's your insulin. And back then, adult beta cells were thought to have either died or be terminally differentiated. So there's no more growth, no more division. You've got what you got. And now newer research, and I'm talking newer over the past 15 years, but it's just more and more coming to light. But it suggests that under certain conditions, beta cells can proliferate, they can divide, they can be replaced. And there are 3 pathways that have some ongoing research in this area. There's proliferation, transdifferentiation, and redifferentiation. And we're going to focus on the last one, the redifferentiation, because we talked about the dedifferentiation of those pancreatic beta cells. And we're going to redifferentiate the dedifferentiated pancreatic beta cells.
I'm going straight to Austin
let
Powers.
me.
Oh no, I've gone cross-eyed.
Okay, the ones that were in the break room with their pajamas on, those ones, those are the ones.
You get them back into the workplace.
Yes, because that's the easiest pathway in this, as far as I understand. And it's the one that responds the fastest to lifestyle change. And so within weeks of reducing visceral fat, within weeks of making changes to your activity level, improving insulin sensitivity, these dormant beta cells can start coming back online. And this is really shown in continuous glucose monitoring data, where the post-meal spikes drop pretty significantly and the fasting blood sugars improve. And usually takes about a month's time before you see that, because those beta cells are just tired and they're on break. They're not dead, thankfully, at least the vast majority of them. Some of them, but the majority of them are still here. And so the other question is who has the most left of different stages of diabetes, type 1, type 2, all of this stuff. So we spoke before about type 1, where you have this honeymoon phase where the pancreatic beta cells are being attacked by the body's own immune system. So usually there's a 6 to 1 year honeymoon period with that, where you still have pancreatic beta cells, but there's some really interesting therapies coming along now that can push this out even longer, where the insulin-producing cells are preserved even longer. So it'll be interesting to see how a lot of that turns out through the years. But specifically for type 2 diabetes, which we mostly, especially when we talk remission, that's what we are the most focused on typically. A lot of our listeners have had type 2 diabetes for 2 years and some for 20. So how much might be left at different stages?
No, and when you say type 2, we're including prediabetes in there as well. Correct.
Yep. But prediabetes is pre-type 2 diabetes.
Let's just call it
a little bit pregnant.
Early stage type 2, because if you don't take care of it, it's going to get worse generally.
Yep. So by the numbers, and everybody's different. So these are rough numbers, just in general, if you will. At diagnosis, on average, people have already lost 50% of their functioning pancreatic beta cells.
Diagnosis of type 2 diabetes.
Diagnosis of type 2 diabetes. Most people walk into that office that day where they're told that they have type 2. Or maybe they're told 2 weeks later when the MA calls them when their lab results come back, unfortunately. And that's because this really starts in prediabetes, years before the diagnosis, because people have had these stressed beta cells for 10 or 15 years before the A1C level ever crosses the diagnosable for diabetes 6.5% A1C threshold. So prediabetes is, to your point, it's not a warning. It is mid-disease when it comes to the pancreatic beta cell burnout.
If you don't want your 8-cylinder vehicle to become a permanent 4-cylinder vehicle, despite the fact that you're not decreasing the load on said engine, you probably want to intervene during prediabetes.
And then after diagnosis without intervention. So to be clear, after diagnosis without intervention, the continued rate of pancreatic beta cell loss is usually 4 to 6% per year. And that's why a lot of people are told that their diabetes is a progressive disease. That's well said. I've said that many times to people, that it is a progressive disease state, all things remaining the same. So the goal is not for all things to remain the same. The goal is for intervention through movement, through exercise, through quality nutrition, through meds where needed, all of these things. Like I say, attack it with everything but the kitchen sink. You want to throw it all at it to get
we've got exercises utilizing the kitchen sink so that those are appropriate as well.
Yeah. So with intervention, very much meaning weight loss. So intervention targeted at weight loss in many cases. And if not like weight loss so much on the scale, but weight loss in terms of how do we reduce any visceral fat that is in existence. And you can really back that up and put that into reverse. And so the earlier you intervene, the more functioning pancreatic beta cells you have, the more that are in the break room to get out of their pajamas and put their work clothes back on as well to recover. And so, of course, someone newly diagnosed with type 2 diabetes is going to have way more functioning beta cells in reserve than someone who's been on insulin for 15 years. But even when people have been diagnosed for 20 years, they still have some functional beta cells left in many cases. It's almost never zero. And the question is not just, can you recover? It's more about how much is possible for you to recover based on how much functioning beta cells you have. So that, of course, brings us to exogenous or injected insulin, because if you don't have any functioning pancreatic beta cells, then you will need to inject insulin. And this isn't a failure. It is just what the disease state calls for. It means that there aren't enough functioning pancreatic beta cells to keep up with the demand of the glucose on the body. It doesn't mean that if you go on insulin that you will always be on insulin. Sometimes it does mean that if you start insulin, throw caution to the wind, give up, stop doing the lifestyle interventions, stop paying attention to your movement and the way that you eat and getting enough fruits and vegetables and fiber and all of that. And I say that knowing that many people are doing all of those things and still need insulin. So I'm not saying that you need insulin because you didn't do those things. I'm merely saying that if you begin insulin with the give up idea in mind, then that can be problematic, because there is still hope that you could potentially come off of it if you regained some pancreatic beta cell function. The reason for so long it has been said that it's not possible is just because not a lot of people do it. It doesn't mean it can't be done. It's just that a lot of people give up at that stage because they've tried in their mind everything for so long. And it's like, well, now I have insulin, I'll just eat what I want, and you can eat what you want regardless, with some bumpers on, if you will, with some caution. Like, I don't eat whatever I want, but I do, if that makes sense. Like, I enjoy salads. I enjoy lentils and lentil soup and beans. And I enjoy fruits and vegetables. So it's hard to say I don't eat what I enjoy. It just is.
There's a lot of retraining. And I think that we've talked about this probably, I guess, not more than necessary because it's still happening, but the diabetogenic environment is real. If you just do what is now considered normal, there's a 50-50 chance that you're going to have prediabetes or type 2 diabetes. That is just the numbers, at least in the U.S. population. Mm-hmm. So that's not you just made bad choices. Like, we're all making almost the same choices, and it's starting to result in just
it's kind of like we're all running uphill.
Disease. Yeah,
we're all running uphill. It's just some of us are more fortunate to stay above the curve while running uphill.
Yeah.
you
Or
know?
maybe just are naturally better uphill runners. But
Yeah.
again, the stress, the environmental stress, all that other kind of stuff is pretty much happening to everybody. So it's not just making bad choices. It's most choices are bad. The most common choices are, I won't say bad. The most common choices done over many years we're now seeing result in this chronic disease state. So yes, absolutely. You're going to have to start doing some air quotes, weird stuff, or at least different stuff. But to fix this at scale, we have to do a better job of making the weird choices, not just normal, but easier to do.
Absolutely.
Less onerous on the individual, because otherwise the path of least resistance is just going to happen more often than not.
Yep.
And we're never going
to roll down that
Yeah,
hill.
exactly.
Yeah. And I want to say insulin is just a tool, just like medications for diabetes are a tool. And sometimes, in many ways, insulin is the kindest tool for your pancreatic beta cells that are exhausted. It is giving them a break and a chance to recover, which is why there was a big push in research years ago that remains to this day is early insulin intervention to try to help give the pancreas a bit of a rest. They don't have to do it all. Let the injected insulin do 80%. So they only have to make up the space where the injection wasn't quite matched to the food or something like that. But it gives it a break. And we're just really taking the pressure off by injecting
something
insulin.
You said before, and again, as the layperson new to this, the thing that's really stuck with me from a strategy standpoint is that if your A1C is over 7, the main focus of whatever it is that you're doing, and probably multiple strategies need to be working towards getting that below 7. Yeah. And when you get it below 7, then we can start talking about instantaneous blood sugar and all that other kind of stuff. But like you said, everything up to and including the kitchen sink that we can throw at this thing to get it below 7 so that we can start tweaking that thing and doing maybe some of the more nuanced, using some of the more nuanced techniques. But if medication is appropriate and is fast, if medication will enable me to quickly go from that 11 to that 8 or 9 or whatever that is, by all means, bring it on, and just understand that that's gonna have to be a temporary tool that I'm going to use.
Scaffolding.
The scaffolding, exactly.
One more thing about insulin before we move on to some habits we can do to help preserve beta cell function. I really want to say to anyone on insulin who's listening, or their spouses, friends, loved ones, please do not contribute to this feeling of being ashamed of insulin. And I definitely have not meant to say anything that would do that, because the medication is not the problem. It is the disease that is the problem. And the medication is in response to what's going on with the disease. So whether you have to take the medication temporarily, the scaffolding, or permanently, a permanent structure or building, it's there to help the pathophysiology behind what's going on, to help fix it until, and it might not even be an until, you can change certain things that are contributing to the problem. And not just you, because you means the agency is all on you, and a lot of it could be, but also to your point and our episode about the environmental factors and the fact that in the 1950s, 1% of the population had type 2 diabetes versus 11 to 12% of the population now. There is something else going on besides individual agency with this. That is known. So that being said, let's talk about some actionable habits to help rest those tired pancreatic beta cells. So, just reduce your visceral fat, every time I say lose weight or reduce visceral fat, it's like, just do it. It's easy. And it's a simple concept, but not easy per se, but it's that fat that's sitting around your internal organs is putting pressure on the pancreas and thus the pancreatic beta cells. And so even a 5 to 10% body weight loss can just completely flip the switch and turn things around in terms of your body's ability to work as it should and overcome the insulin resistance that's going on. So you want to walk, sleep better, reducing high fructose corn syrup and highly processed foods, having some strength training, fiber and protein can really help with that regards as well. There's so many research studies, well-conducted studies about fiber and inflammation, which can have an effect on all of these things.
Yeah, I'm going
fiber
to
and cholesterol.
Just give a shout out to our Fiber is the New Protein episode. There's a big push nationally right now to get protein up in the diet, and 90% of people get adequate protein. 90% of people also do not get adequate fiber. So to me, just the big opportunities there, if you just intentionally work towards getting that adequate fiber, just getting the recommended, not even a mega dose, getting the recommended amount of fiber in your diet every day, that really does meaningfully affect the adiposity around your organs.
A little aside to that, when you go to school for nutrition and dietetics, you learn about protein energy malnutrition, and you learn these really weird names that they're called. You have kwashiorkor, which is protein energy malnutrition, which means you're deficient in protein and nutrition, and then marasmus, where you're deficient in calories overall, period. So marasmus looks like this complete wasting, like skeleton type.
Like anorexia almost, or is it?
Well, it's usually more in like sub-Saharan Africa where you see these type of diagnoses,
Famine,
but
basically.
They can happen in some cachexic cancer patients and things like that. But yeah, and yes, in anorexia, you can see this as well. But then you also have kwashiorkor, which is where you might see these kids. I remember when I was younger, seeing kids with the large abdomens, and it's like, well, they don't look like they're hungry. Look how big their belly is. Just being a kid and being naive. But that is a sign of not having enough protein in the diet. And you can ask any physician in this country, they are not handing out kwashiorkor diagnoses here. We are not protein deficient. We do not know famine and we're not protein deficient.
Yeah.
As a whole. There are some people that are, but speaking in general terms, no. We are more fiber deficient. That is absolutely a thing. Yeah. So then sleep 7 to 9 hours. I feel like the end of our podcast, we're saying the same thing over and over, which I don't mind because repetition is the master of skill. So I hope that if you hear these things over and over, a couple of things will stick. Oh, hey, maybe I want to look at that bread and make sure the number one ingredient is 100% whole wheat instead of refined white flour so that I get more fiber. And then also managing stress, because stress management, it's almost like you manage your stress, you help manage the stress of those beta cells. So they don't have to go put their pajamas on in the break room. And then for medication, so that's the lifestyle habits that you can do. And so where do meds fit into this beta cell rest? And of course, we talked about insulin. Insulin is the biggest one, I would say, that fits into giving the beta cells a break. But then the opposite side of that, and I know that a lot of endocrinologists, especially some of the older endocrinologists, I don't want to age any endocrinologists. Let me just say that there's a great benefit to thiazolidinediones, and the way that they work in the body is one of the only things that help overcome insulin resistance. But also, they can have the beta cells burn out more quickly because it's like that horse that's already running as fast as they can in the race, and you're cracking the whip at that horse. Like, they're only going to go so fast, and then you burn them out by cracking the whip on that. And that's what your sulfonylureas do. They're often prescribed because the mechanism of action is good, and they're very cheap. So they're effective and they're cheap, but they can also create faster pancreatic beta cell burnout. At least there are enough studies to suggest that. You could probably debate that with a few studies as well. So it's, Then you've got the newer classes of GLP-1 receptor agonists, Ozempic, Mounjaro, Zepbound, Wegovy. So these can help beta cell function in that they can help reduce visceral fat. So you reduce visceral fat, you increase insulin sensitivity, and you reduce the workload of the beta cells by doing those things, and also reducing inflammation by reducing the visceral fat, and also reducing the fat stored in the liver. So it can reduce the hepatosteatosis, so the fat that's stored in the liver. And then you have your SGLT2 inhibitors like Jardiance, Farxiga, Invokana, and those work by making your kidneys excrete when the blood sugar is over like 280. You'll excrete that excess sugar into the urine, and it also has this passive diffusion and helps with blood pressure as well. And
weren't there some really nasty side effects with those, though?
A lot of the side effects with these drugs are also side effects with having diabetes in general, but they can increase some. I would say one of the nastiest ones, of course, is Fournier's gangrene, but this can also happen in people who have type 2 diabetes. But basically, when you're urinating out excess sugar, you have more sugar in areas that could feed bacteria or yeast and things like that. So some people definitely increased female genital mycotic infections could be a side effect of that. But other than that, a helpful class of drugs for protecting the kidneys. And there's some research on heart failure risk reduction. So with that too. Then you've got metformin, one of the most prescribed diabetes drugs in the world. Metformin primarily works by telling the liver to release less glucose into the bloodstream. So with less glucose circulating in the bloodstream, the pancreas doesn't have to produce as much insulin to keep the blood sugars in range. And that's all part of reducing the stress on the beta cells. So it's very cheap. Many other long-term benefits of metformin. And of course, the worst side effect would be diarrhea, well-known side effect of metformin, which is why extended release versions are very helpful, making sure to titrate up from the lowest dose of 500 milligrams to eventually getting up to the max dose of 2,000 milligrams as needed. And we talked about insulin. So the whole field of diabetes has very much shifted to beta cell rest, trying to preserve the pancreatic beta cells. And when you lower them, if you're protecting the functioning beta cells in the process. So if you're on a sulfonylurea and don't really know why, or if you're not taking that sulfonylurea 30 minutes before you eat, you might want to have a discussion with your healthcare provider about that. But that's pretty much everything you never wanted to know about the pancreatic beta cells.
All right. So I think the big kind of takeaway for today is do whatever you need to do as soon as humanly possible to start moving that thing in the right direction. If you were just diagnosed with prediabetes, understand, great, you've got way more opportunity and way more functioning beta cells than if you just see what happens, which is the normal recommendation.
Yeah.
If you've got
Yeah.
If you just got diagnosed
one reason
with,
why it's infuriating to me when people come in diagnosed with prediabetes and it's just waiting, change your, eat less, avoid white foods, work hard, and I'll see you in 6 months or a year. That is a key time to make a change, is a very large missed opportunity.
but not just that, for those that are just diagnosed with type 2, just the knowledge that you have 50% functioning beta cells, well, that's almost a glass half empty or a glass half full analogy. Great. You still have half left right now. That to me is a really good sign that, you know what, I'm going to do everything I can to protect the half that I still have, rather than this is all of it, regardless of where you are on the spectrum, requires action. You're going to have to do some things different, and not just one thing. You're going to have to do probably a bunch of different stuff, but the best part of that is you don't have to be perfect at all of it today. You just need to start intentionally saying, today is as bad as it's going to get. I'm going to do whatever I need to do to make sure that the rest of my life is as good as it can be.
Absolutely.
I think that's it. So thanks for tuning in. And this has been another episode of the Diabetes Podcast. That concludes our series revisiting the 12 core deficiencies of diabetes. Remember, new episodes launch every Monday. Please subscribe to the channel if you haven't done so already. And until next time, take courage. You can do this, and we can help.